So as Nancy mentioned, this is really about things that have been done in the past and how this can help us shape the next phase of the various gene therapy programs which are ongoing, not just for Leber's optic neuropathy, but for other inherited optic neuropathies. So these are my financial disclosures. And for the people in the audience joining this international forum for the first time, Leber's optic neuropathy, also known as LHON or LHON, is a primary mitochondrial genetic disorder. At least in the United Kingdom, the minimum prevalence is 1 in 30,000. There are 3 common mutations referred to by their locations in the mitochondrial genome: 3, 4, 6, 0, 11, 7, 7, 8, and 14, 4, 8, 4. These percentages refer to the UK epidemiological data, and the 11, 7, 7 mutation accounts for roughly around 60% of cases. Of course, in other countries like in China, this is much higher, accounting for about 90% of the LHON population. The rather unfortunate fact about Leber's optic neuropathy is that it has a very poor visual prognosis. The rate of spontaneous visual recovery is less than 15% for the most common 11, 7, 7, 8 mutation, and most of these patients will remain within the legal criteria for blind registration in the UK. Hence the need to look for treatment that can at least stop the disease process once it has started. The obvious therapeutic approach is gene therapy, and the focus has been on the specific therapeutic approach of allotopic gene expression. The reason for this is because it's very difficult to insert a gene directly into the mitochondrial compartment for various reasons. And therefore, what you do is you use a recoded version of the gene of interest, in this case ND4 for the 11, 7, 7, 8 mutation. It gets inserted into the nuclear genome, the mRNA is produced, the protein is produced. And what is quite specific about this approach is it has a specific mitochondrial targeting sequence, which allows the protein to be transferred reasonably efficiently into the mitochondrial compartment. A number of studies have been conducted stretching more than 10 years from now. The work done by José Saël and Marisol Corral-Debrinsky in Paris, and the work of the late Dr. John Guy at Bascom Palmer, showing that allotopic gene expression can be used to rescue retinal ganglion cells with preservation of visual function. This led to the initiation of early phase clinical studies and the development of specific AAV2 viral vectors that contain the recoded ND4 genetic construct. So this is just a cartoon here which shows the AAV2 vector with the ND4 replacement gene flanked by the mitochondrial targeting sequence. And the good thing about doing work with ocular gene therapy is that we can do a reasonably straightforward intravitreal injection without any need for any more invasive procedures. I'm presenting here the data from the GenSci trials, and the preclinical work led on to phase 1 and phase 3 clinical studies, and I'm going to briefly mention Rescue, Reverse, and Reflect. This was a massive effort, and a number of the people taking part in this international forum are listed here in the list of collaborators. And the good thing about doing clinical trials now is that there's a very extensive network of clinicians and also patient organizations which are helping greatly in terms of making the recruitment faster and efficient. So briefly, there were 2 studies: Rescue, which recruited patients with a confirmed 11, 7, 7, 8 mutation with disease duration of 0 to 6 months. Reverse was from 6 to 12 months. And one eye was injected with a gene therapy vector, and the other eye was a sham injection. 39 patients were recruited into Rescue, 37 patients were recruited into Reverse. And the studies have been published now. For the sake of brevity, I'm just referring here to the original papers, which you can read in greater detail. So here you can see the change in best corrected visual acuity on the y-axis, and on the x-axis you have the time from the time of injection. And as the line is going down, this means that vision is getting worse. Unfortunately, as we can see here from the Rescue study, we were not able to prevent the catastrophic loss of visual acuity in the subacute dynamic phase. And vision continued to deteriorate quite rapidly, reaching the nadir. And what was quite clear from the Rescue study is that we could not prevent the second eye involvement, and we do not stop the acute visual loss seen in the acute stage, which was disappointing, but that was the main observation. What happened afterwards was much more promising, in the sense that there was a bilateral improvement, but in both the treated arm and the sham eye. Overall, the treatment was safe and well tolerated. Vision improved in around 78% of treated patients 2 years after an intravitreal injection of the viral vector had been given. As rescue and reverse were progressing, the REFLECT trial was being designed, and REFLECT again recruited patients with the 11.778 mutation. And here we were looking at the efficacy and safety of a bilateral injection of the gene therapy vector. And patients were recruited with disease duration of up to 1 year. An impressive number of patients were recruited and randomized from 13 centers, 98 patients in total. And again, the main results have now been published at the end of last year in Brain. And of the 98 patients that were recruited, 58 had injection of the gene therapy vector in both eyes. In 40 patients, one eye was injected with the gene therapy vector, and the other eye had a placebo injection of balanced salt solution. Without going into any great detail, what you can see here from this graph is that vision improved in all 4 groups at 2 years of follow-up. And although the difference is still small at this time point, there was the suggestion that bilateral treatment was more beneficial than unilateral treatment. But of course, this raises a number of questions which will be addressed by other speakers in this international forum. And I think the first thing is really about the therapeutic window, meaning who should we treat and when, until when is the treatment going to be effective? I think the first thing that I've already mentioned is that we could not prevent the very rapid loss of visual acuity seen in the subacute phase of the disease process. And it is possible that once you have initiated the loss of these retinal ganglion cells, you cannot really prevent the bulk of them from being lost in the first place. And the other rather interesting observation, and we don't know yet whether this is a real effect, is that it seemed to be the case that patients in reverse seem to do better compared with those in rescue, which is counterintuitive, because the reason for having these 2 studies was on the premise that patients in rescue being treated earlier would do better. So I think we need to look into this further as to whether or not this is real, and if it is real, what is the reason for this? The other question is, the 3 phase 3 clinical trials have recruited patients with disease duration of up to 1 year. And therefore, the question is, do patients with longer disease duration benefit from gene therapy? And there is data emerging. You will hear more about the data from the Chinese studies. But based on the GS10 cohort, there was an early access program in 3 countries. 4 countries actually: France, Italy, the UK, and the US. 63 patients were recruited into this early access program, and you will note that about 3/4 of this cohort were also treated with idebenone. What was quite interesting is that 1/3 of the patients were treated more than 12 months after the onset of the disease. And if you look at the graph here, you can see that there is an improvement in visual acuity from the nadir, and that also was reflected in the chronic patient group. And also importantly, there was a favorable safety profile, which was consistent with what was being observed in the phase 3 clinical trials. Hopefully, all being well, there will also be a trial starting the 3rd quarter of 2024 called the REVIVE trial, funded by the NIHR, which is a funding body in the UK. And again, looking at this question of whether patients with chronic lung will benefit from gene therapy. This will be a pilot study including 30 patients with the 11.778 mutation and disease duration between 18 months and 5 years. Patients will be randomized 1-to-1 to bilateral injection with GS10 or to sham treatment. I've already mentioned that the whole premise of gene therapy for the 11.778 mutation is based on allotopic gene expression, which still remains controversial in the sense that there has not yet been conclusive evidence that the imported ND4 subunit is actually integrating and assembling properly into what is a rather large complex one. So a lot more work needs to be done into the basic science underpinning this therapeutic approach. The other thing also which is still controversial is how much transductions are you getting from an intravitreal injection of the gene therapy vector. and especially, what is the proportion of retinal ganglion cell within the papillomacular bundle, which is being effectively targeted by this gene therapy approach. Obviously, a lot of people are looking at how to improve the efficiency of retinal ganglion cell transduction, and one way of doing this is to develop better gene delivery systems. So this is a very active area of research because although we're using AAV2 viral vectors, people are designing new viral envelopes which are designed to allow a much more rapid and efficient transduction of these retinal ganglion cells. And of course, safety will need to be explored further. The other thing that can be added as a safety mechanism is to use promoters that will allow the transgene to be expressed only in the cells of interest, in our case, in the context of Leber's optic neuropathy, the retinal ganglion cell. As I mentioned already, if you're going to be targeting these retinal ganglion cells, the one that you really want to hit are the retinal ganglion cells within the papillomacular bundle, because this is what potentially can improve your central vision to a greater extent. And we're relying on an intravitreal injection, which some people would argue is a little bit of a random way of providing the gene therapy vector. And nowadays, with the development of robotic assistance, it is possible that very soon there will be ways of injecting your gene therapy vector of interest very close to the optic nerve head. And this is work that is being done in Oxford. Dr. Sidney Gospi is going to talk about this in greater length, but this was something that was very unexpected and still not fully explained about why you're getting this bilateral improvement in both the treated eye and the sham eye. And this is not something which is specific to the gene therapy vector used for the GenSci trials, because this has also been observed in the cohort of patients treated by Dr. John Guy and his team from Bascom Palmer, and also the various studies that have been coordinated by Professor Li Bin in China. So clearly, we can't use a fellow untreated eye as internal control. There has also been a press release from GenSci recently indicating that they will be running another phase 3 clinical trial referred to as the RECOVER trial. And here, patients will be randomized to either sham treatment or to bilateral injection with GS10. Patients will have disease between 6 and 18 months, and one criteria will be that they must have reached a visual nadir, which will help in terms of simplifying the statistical analysis. And I think just to close this presentation, I think the other important thing we need to keep in mind is, do we have the right set of outcome measures to eventually convince the regulators, the EMA in Europe, the FDA in the US, that we have actually shown benefit from a specific treatment? And you have to set a primary outcome measure, and although this is easy to say, in practice, it's not always straightforward until you've actually run the study. And how do you define this? Will the regulators accept 10 letters improvement, 15 letters improvement? Will they accept responder rates? For example, one which has been used quite extensively is the clinically relevant recovery responder analysis. And then also whether other secondary structural and functional outcome measures can be used to support the evidence of a specific treatment working in Leber's optic neuropathy. Even after you get marketing authorization, you still need to get the treatment paid for. For example, in the UK, we will need to get approval from NICE or MHRA, and this is not a straightforward business, because even if the drug has been approved by the EMA, they will still want to know whether the drug is cost effective before they're going to approve this. And one of the challenges that we have is we do not have a lot of data on how to demonstrate true patient benefit. And one way of getting around this, and it is something that is now being looked into much more closely, is the use of these patient-reported outcome measures, because this is something which allows you to demonstrate that a change in visual parameter, be it visual acuity or visual field, is actually having positive impact on how the person is interacting with the environment. Some of these generic prompts have been used, for example, the VFQ-25 or the VF14, but these have never been designed for LHON or any other inherited optic neuropathies. And as you will see in the coming months from various presentations, there are limitations to using these generic prompts. And just a quick mention that we are doing work on this in Cambridge. One of the fellows in Cambridge, Benson Chen, has developed and validated a prompt for Leber's optic neuropathy, which is now ready for inclusion in future clinical trials and natural history studies. So in summary, this is an exciting field. Gene therapy is leading the way in terms of mitochondrial therapeutics. It is quite clear that future clinical trials will need to incorporate control arm, at least sham injection. We still need to clarify the therapeutic window of this intervention. And then finally, besides all the other usual things that we measure, we have to consider using patient-reported outcome measures, because in due course, you will need that to convince the regulators about paying for expensive treatment. Thank you very much.